Hello everyone and welcome to our first video on training supervision. In this video we'll be covering supervised learning. So a quick overview of what training supervision is. It is one of the ways to classify machine learning, which we covered in a previous video. And it is defined as how an algorithm is taught, and it is categorized by how much human intervention occurred when a data set was given to the algorithm. The types are supervised, unsupervised, semi-supervised, and self-supervised. In this video today, we are covering supervised learning. So in supervised learning, you feed the algorithm a training set. Importantly, and by definition, this training set will include the desired solutions. And these desired solutions are called labels in technical terms, or targets. Two types of predictions can come from this kind of data set. The first is classification, and the second is regression. In a classification type of supervised learning, what the model predicts are categories, whereas in a regression, the model predicts numerical values, and we'll demonstrate both of these next. So your first question is that you have a data set of brain MRI scans with tumors in them. Each scan is labeled, so here are the labels, as benign or malignant. And these have been labeled by the radiologists, but what you want to do is train the computer to detect whether future MRI scans are benign or malignant. How can we do this? Well, you use something called classification. In classification, a machine learns to put whatever you input, in our case the MRI scans, into a category, so benign or malignant. What you do is train the algorithm, so you train the computer with many example MRIs, so previous MRIs, and whether those MRIs were benign or malignant. So you give it the data set, and then from that, it learns how to classify each new example into a class. And once it has learned this, it does this without your intervention. So step by step, you give it the MRI brain, it classifies it, and what it outputs is whether the scan shows a benign tumor or a malignant one. Next question. You want to predict a new patient's fasting glucose level in millimoles per liter. A problem that clinicians often face is that we know that fasting glucose levels are the most reliable glucose levels for predicting diabetes. However, patients are often not able to fast for whatever reason. They might be hungry, they might have been hungry, or they might have just forgotten. And if they have not been fasting, we would have to take something called a random blood glucose level, and that's often not as reliable. So assume that it is a patient's appointment, they've come, and they've told you that they have broken their fast, but it's still important for you to predict what their fasting glucose level is, because it would indicate whether they have diabetes or not. Well, let's say we're in that situation and now we want to predict a new patient's fasting glucose level. What we do have is the patient's age. So all of these are risk factors for diabetes. Patient's age, their BMI, their daily sugar intake, exercise frequency, family history of diabetes, and medications that they use. And the question we're answering is, how can we use this information to predict the fasting blood glucose? We use something called regression. In regression, again, you give the algorithm many examples, and each example has features which are the previous patient's information, so the risk factors that we just mentioned. And each example also has a target, and the target is the number, the output. So in our example, the previous patient's fasting glucose. So the question, what we're trying to teach it, is given these features, what is the target? What is the blood glucose? So given the risk factors, what is the fasting glucose? What the algorithm does is find the mathematical link between features and the target, and predicts the target based on inputted features for new patients. Now, a final question. A patient has atrial fibrillation, which is a very simplified, abnormal heart rate. This increases chances of stroke. So what you want to do is predict their risk of stroke. And the reason you want to do that is you want to answer the question, should you give preventive medications or not? Normally, you would say, yes, of course, why would you not give preventive medications? However, here, anticoagulants, which are the medications, anticoagulants have side effects. And the one we're most worried about is bleeding. An increased bleeding tendency. We want to know, is this increased bleeding tendency worth it for their risk of stroke? Okay, so to break this down further, what you do know are the risk factors for stroke. So there's congestive heart failure, hypertension, age, diabetes again, previous stroke, previous vascular disease, and the patient's sex. What you want to know is how each of these risk factors increases the chance of stroke, whether alone or in combination. It's time to learn about logistic regression. Logistic regression is a mix of regression and classification. So there's two steps, and first is regression. What it does is it finds the probability of a certain example. So here, probability of stroke, in our example, of a certain patient. And this is based on the risk factors that we mentioned, based on risk factors. And then it converts that probability that we got from the regression into a category. And this second step is the same as classification. And this category are the points, or like points for stroke. Points for stroke, where higher points equals higher risk. And this will make more sense in a second. So here's how we'd use logistic regression algorithm for stroke. First, again, you would give the algorithm details of many hundreds of thousands of previous patients with atrial fibrillation. And by details, we mean their risk factors. And you would also give the algorithm whether or not those previous patients ended up having a stroke or not. Then the algorithm would run regression. So with risk factor XYZ, what is the probability, should I say, of any patient getting a stroke. So for each risk factor, what is the probability of stroke? Then it would convert that risk probability, so this probability would be converted here, this probability to a number. So points. These are the points that I was talking about in the previous slide. And these steps, they actually did this very, very nicely, and clinicians use it regularly, and it's called the Chad's-Vask score. So each of these letters stands for each of these risk factors for stroke in an atrial fibrillation patient. And based on the classification, converting the risk percent to numbers, each of these risk factors was given a certain number of points. For example, let's say that our patient, this new patient that's coming in, has congestive heart failure. They're greater than or equal to 75 years old. They are a female. Okay, so so what clinicians do is add up these scores. So that would mean 1 plus 2 plus 1, which equals 4. That's 4 points. And that will indicate, based on guidelines, whether to medicate or not. Most guidelines currently are at, if the risk is higher than 1% per year, then medicate, because the benefits outweigh the risks of bleeding. But if the risk of stroke is less than 1% per year, don't medicate, because in this case, the risk of bleeding would outweigh the benefit of preventing stroke. The 1% is actually converted to points as well, and that is in males. If your score is greater than or equal to 2, what you do is medicate. If you have a female patient, if your score is greater than or equal to 3, you medicate as well. Because these points, so 2 or 3 for male or female respectively, indicate greater than or equal to 1% risk of stroke. So if this patient, our female patient, had 4 points from their Chad's-Vask score, we would look at this guideline, which is females greater than or equal to 3. Is it greater than or equal to 3? Yes. So therefore we medicate.